So, dear colleagues, it's a pleasure to me to announce the next session detailing hepatocellular carcinoma and liver transplantation. And it's a pleasure for me to announce the first presenter. It's Professor Popescu, who talks about liver transplant for hepatocellular carcinoma.
Ladies and gentlemen, good afternoon. First of all, I would like to thank the organizers for the kind invitation. This is one of my favorite topics. I hope to make it in time. And why it's one of my favorites? Because I think we have a good policy towards the candidates to liver transplantation and also pretty good results, I would say. Well, I don't know. Oh, okay.
You can use
The other one. Oh, okay. Okay, large is forward. Well, I will go quickly on those details related to the frequency. We know it's high incidences of all over the world, sorry. And yeah. Most of HCC is on cirrhotic patients. Actually, my talk would be focused on HCC in cirrhotic patients, more or less. Low survival so far. What therapy we have today? So these methods, starting with liver resection, mainly on normal liver or limited resection in cirrhotics, liver transplantation, ablation, transarterial chemoembolization, anti-angiogenic therapies recently, checkpoint inhibitors, radiotherapy. Staging is essential, and everybody knows Barcelona system, BCLC, so there were attempts to modify this, to replace this. Still, for us, it remains the most useful classification and probably the most widely used. And here, I think we have these three stages: early stages, intermediate, and advanced. And the curative methods are applicable only in early stages. I will come back during this presentation on the idea. Ideally would be to detect the HCC nodules when they are below 2 centimeters. Theoretically, this should be possible monitoring cirrhotic patients because this is a gastroenterology community, and all the cirrhotic patients should be monitored by a gastroenterologist and ultrasonographist at the same time. So here we had discussion in Funden, and according to Professor Liana Gheorghe, so officially all over the world it's 6 months interval of monitoring. But it's also my feeling, and what she says, 3 months would be better. If you can afford to monitor every 3 months the patient, then most probably you will discover these nodules when they are below 2 centimeters. And if you have a diagnosis in these early stages, then you can do whatever, even resection or ablation, but by far the best results are using liver transplantation. The only problem is that we don't have enough livers, but otherwise, because liver transplantation cures both the cancer and the underlying cirrhosis, then it's definitely the best method. Again, the same idea, early diagnosis is the key for cure, and again, the idea of monitoring and of good imagery and progress in the imagery has been done recently, as you know. Now, with the same idea as in breast, we have a LIRAD system of describing the radiologic images in liver nodules, together with the markers and sometimes with the biopsy, we have all the means in order to diagnose an early hepatocellular carcinoma. And here see in Japan and Hong Kong, in Japan where there is, as many things in Japanese medicine, a very good program of monitoring cirrhotic patients, 75% of cases detected by surveillance with a median survival time of 52 months. while in Hong Kong, where there is not such program, less than 20% of cases are detected by surveillance, and the mean survival time is definitely much lower. This is a number of patients treated for HCC in our department. You can see that liver transplantation represents a fair amount among the three methods, resection, ablation, and transplantation. It's an important cohort of patients treated by liver transplantation. If we talk about liver transplantation in HCC, except BCLC, another crucial notion is the so-called Milan criteria. Probably all of you know those criteria. It's either one nodule less than 5 centimeters or no more than 3 nodules, each one less than 3 centimeters. If the patient and if the tumor is within Milan criteria, then the results are good. This was observed from the beginning of the liver transplant program all over the world. The survival was almost similar with the so-called incidentalomas and practically similar to the normal liver with no cancer. While in when we are beyond Milan criteria, the results are worse, definitely. And we will see during the presentation, there is so-called metro ticket. Metro ticket means that the further we go, the worse the results. The more the nodules, the diameter of the nodules is bigger, or the number, the worse the results. But the problem is, what do we want from the patient? How do we assess the results? And if we talk about, let's say, 2 years survival instead of an indefinite survival or a similar survival according to the age of the patients, it looks a very big difference. But if we talk about 2 years or even 1 year compared with the palliative methods, then we realize that it's much more than any other method, and mainly chemotherapy, that can be used. So what I want to emphasize is we can go beyond Milan criteria if we know, and the patient knows, and the family knows, that we don't have great expectations, but the expectations we do have are much better than with any other therapeutical method. This is the metro ticket. It's easy to understand. So the further we go beyond Milan criteria, the worse the results. But still better than with any other therapeutical method. Again, coming back to the BCLC classification, is the idea that the earlier the phase and the earlier the diagnosis, the better the results, for sure. And now, coming back to what I said before, in the intermediate phase, so usually liver transplantation in early phase, excellent results, but in an intermediate phase, usually this was a phase of chemoembolization and stabilization of disease, and that's it. Now, if we accept the idea that I emphasized before, liver transplantation becomes an option, and especially when we have a living donor in the family that wants to donate for the patient, and the patient knows and the donor knows that he will survive maybe 1 year or 1 year and a half or 2 years, but this will be a good period of time, and everybody accepts the situation. Liver transplantation becomes an option for the intermediate phase. Here, the extended, the Milan criteria, UCSF criteria, up to 7 criteria. There are many other offers, let's say, for indication of transplantation. And of course, here are the results. You will see the more we go beyond what I said before, the worse the results. One important point in liver transplantation for HCC was the immunosuppression, because as with any cancer, so the postoperative immunosuppression could well actually favor the recurrence of disease and systemic dissemination of recurrent disease. Those mTOR inhibitors, sirolimus or more recent everolimus, seems to decrease recurrence because they are also anti-proliferative agents at the same time. So therefore, for those patients, the standard immunotherapy is based on mTOR inhibitors. This is our experience in 187 transplants in 182 patients. I won't go into details with demography, but what we have to see is that, well, here, a fair number of patients were beyond Milan criteria. We are quite liberal to transplant those patients, and sometimes we, as we will see, we had some pleasant surprises. So if, again, the family and the patient accepts that this is a, let's say, risky option, but everybody accepts it, sometimes the results can be surprisingly good. Morbidity and mortality and retransplantation, the same as in literature. As you can see, most of the patients were transplanted with the whole liver from a cadaveric donor, but 31 of those patients were transplanted with a living donor. Sometimes we use the split procedure, and in one case the domino procedure. And this is our policy. So for HCC within Milan criteria, where we expect very good results, so we had the same allocation system as in normal livers, so a good cadaveric donor. But if we are beyond Milan criteria, we use quite often the marginal donors or the living donors. Marginal donor means that it's a marginal liver, fatty liver, long stay in the ICU, age donor, and things like this. This is a bridging therapy for most of the patients on the waiting list to use most of the time chemoembolization. Otherwise, sometimes liver resection or ablation, preparing them for liver transplant. Chemotherapy for downstaging, we got it in some cases, so downstaging gives and improves the prognosis for sure. And the response to taste is a biological criterion and an important prognostic factor. So the responders have a much better survival than the non-responders. This is the pre-transplant therapy. Most of the time, as you see, we do chemoembolization. While the patient is waiting on the list, we chemoembolize most of them. And, well, this is the survival curve according of the pre-liver transplant treatment. This is the marginal liver graft that I was discussed before and the criteria. So we use many of those livers, especially because we have this machine now, and we put the liver on the machine, and the machine can tell us if the liver is going to make it or not, because before it was just a bet with the chance. Some of those livers did not function, and they had to be replaced, or the patient died with a primary non-function. Now the machine allows us to use more safely the marginal livers, because we can predict which is going to work and which is not going to work. The donor-recipient matching, so the worse the liver, in better shape should be the recipient. Therefore, the HCC, the cancer patient, is very fit for this, because usually there is the cancer that dictates the urgency of transplantation and not the MELD score. These patients have very low MELD scores, some of them, so they are in good condition and they can tolerate a bad liver. This is an example of what can we get sometimes. This is a large ACC, 10 centimeters, very large, with a high AFP, and we perform chemoembolization. Usually, even we got a complication, was a rupture of the tumor. The patient was operated on an emergency basis, but still, the patient make it to transplantation, was transplanted in July 2007, and see, for a large tumor beyond Milan, for sure beyond Milan, we have more than 10 years of survival. Living donor is also good, as I mentioned, because the donor donates only for that patient and accepts both donor and patients the prognosis, which is not optimal. Operation can be scheduled. There is no rush. There is no weekend. There is no night. Can be prepared. Of course, there is the risk of the donor, but I won't go into details. So far, we didn't have any death in our program. Some complication, usually minor in donors, and this is practically the main risk when we do living donation. These are the survival rates in general. So long-term survival and recurrence-free survival. As you can see, 87% at 1 year and still 64% at 5 years could be considered decent numbers. That's why, as I said in the beginning, I consider that the results for such a terrible disease can be considered good so far. inside and outside Milan criteria, of course, there is a difference. AFP is a very good criterion for prognosis. So if it's more than 400, as you can see, prognosis is poor. Therefore, we should use this criterion when we consider transplantation. Deceased donor or living donor almost the same, so either we use a fragment or a whole liver, similar results. Very important to have a multidisciplinary approach, and actually in the weekly meetings we are there, the gastroenterologists, surgeons, invasive radiologists, and pathologists. Everybody is there in order to get the best conclusions and indications. Compared with resection and ablation, you see transplantation has by far the best survival curve. You can see it's on top. Liver transplantation offers the best results. Sometimes we can get recurrence. Here, sure, the possibilities are very limited. I won't insist because, retransplanting a patient with a recurrence is not really an option. Most of them are sorafenib, get only sorafenib, and survival is quite limited. In conclusion, let's say liver transplantation provides the best recurrence-free survival and the best chance for cure of HCC, especially on decompensated cirrhosis, due to the complete removal of all hepatic HCC disease and all oncogenic cirrhotic liver. They so cures both the underlying disease and the HCC, and sometimes unseen foci of hepatocarcinoma in other places. And even in outside Milan criteria, liver transplantation may provide optimal long-term results compared to other treatments that we have today. Tumor number and size are the main parameters accepted for prognosis. Biological markers, as AFP, may play an important role in predicting recurrence, and maybe in the future other pathological markers like venous invasion or degree of differentiation or other markers of aggressivity. Patients should not be denied radical treatment based only on poor prognostic factors. As carefully selected patients, and you notice the example that I gave, can undergo curative treatment with excellent outcomes. Thus, through multidisciplinary consideration of each patient is mandatory, and I strongly recommend those meetings, common meetings. And prospective investigation of factors related to tumor behavior and treatment efficacy correlated with research in the genetic profiling of HCC may provide a more precise algorithm for treatment selection in HCC patients. Finally, living-related, it's easier and safer. And this is a conclusion that, well, actually, I would like to skip because it's comparing liver resection with liver transplantation. Well, I spoke in this presentation mainly about liver transplantation. Again, transplantation is far better if we will have enough livers. Resection is still an option, especially on normal liver, but this is not the object of this presentation. And I thank you very much for your kind attention.
Thank you very much for this excellent and very straight presentation. I have a short question regarding your policy. You mentioned that you use mTOR inhibitors to reduce recurrence rate. There are not uniform results in literature. We have the Silver study where it is predominantly beneficial for patients who are within Milan. Do you stratify your patients after liver transplantation to give them mTOR inhibitors according within or without Milan, or do you put every HCC patients on monotherapy with mTOR?
Honestly, we don't have criteria, so we try to put every patient on mTOR. But fact is that some of them we have to switch to tacrolimus because of immunological reasons. And honestly, even the patients that stay and keep being on mTOR inhibitors, I'm not so sure that they are really protecting against recurrence.
Mm-hmm. Okay, thank you.
Not to speak that I would like to have veronimus, which we don't have, so we have to face the side effects of veronimus quite a lot.
Yeah, that's true. Any other question? Okay, if this is not the case, we would like to announce the second speaker, and the second speaker deals with the presentation Systemic Therapies for HCC, Immune Checkpoint and Signal Pathway Inhibitors. Dr. Koitoro.
Yes, thank you. Dear chairs, dear colleagues, thank you for inviting me to have a talk about systemic therapy in HCC. I will speak mainly about targeted therapy and some words about immune checkpoint inhibitor. These are my disclosure of my potential conflict of interest in the last 2 years, and my agenda. In my agenda, I will discuss about advanced disease and what we have here, the first two players, sorafenib and lenvatinib, in first line of therapy for advanced HCC, and how we continue at progression. And I will highlight only on true positive second-line therapy with regorafenib, cabozantinib, ramucirumab, pembro, and nivolumab, and some words about combination therapy. Every one of us knows very well the result of SHARP trial and Asia Pacific trial, which put sorafenib as the first treatment in advanced hepatocellular carcinoma. And every one of us knows that with a very good hazard ratio of 0.69, and in Asia Pacific trial with the same results. Meta-analysis of these two trials shows that, all the patients had benefit irrespective of prognostic factors from sorafenib, but lack of extrahepatic disease and macrovascular invasion and neutrophil lymphocyte ratio, lower neutrophil lymphocyte ratio were predictive for a greater overall survival. Sorafenib had the best results for the patient with HCV infection from ex-Asia. As you can see, the overall survival higher than 18 months. The other player in first line is lenvatinib. I don't know what happened with her. No much. Lenvatinib, which is a multi-target, yes, is a multi-target drug which could inhibit RET, c-KIT, PDGFR receptor, and VEGFR receptor, and also fibroblast growth factor. And probably this could explain the result of this REFLECT trial. REFLECT trial, where lenvatinib was compared with sorafenib, was a non-inferiority phase 3 trial in patients untreated with other systemic therapy, and where lenvatinib showed a little bit better overall survival, 13.6 months versus sorafenib 12.3 months. I don't know what happened with my presentation. Probably something wrong with some animation. No, I don't know where. Yes. how it's working, but too fast. Sorry. Mai. Here, here. Și ăsta este în față. Ok. Dar n-am folosit ăla de sus. Multivariate analysis for lenvatinib shows that the patient had a better overall survival treated with lenvatinib if they had alpha-fetoprotein higher than 200 nanogram per milliliter, microvascular invasion, and HCV. And what happened where is the resistance to sorafenib? They found what happened, and probably you can see the data that the acquired resistance to sorafenib is driven by activation of insulin growth factor and fibroblast growth factor. You can see the bar, the high bar, with these results. And probably this drug could have an inhibition of this response. Regorafenib is one of these multi-drug inhibitor, and the difference between sorafenib and regorafenib is 1 fluorine atom, but regarding the inhibitory activity of regorafenib is a little bit higher than sorafenib, as you can see the data. A resource trial where the patient with HCC with documented radiological progression during sorafenib treatment were treated on regorafenib and placebo showed that the overall survival was 10.6 months for regorafenib and 7.8 months for placebo. And another drug utilized in patients with advanced hepatocellular carcinoma and progressing on sorafenib was cabozantinib, a MEK inhibitor, and Celestial trial show better overall survival for this drug, 10.2 months versus placebo, 8.5 months. Nu știu ce să fac, chiar e foarte nasol. Da, acolo fac, n-a degeaba. Acum vreau înapoi. Regarding the multivariate analysis for cabozantinib, the patient with extrahepatic disease and microvascular invasion has better results and patient with HBV infection. Regarding the other drug which is not a targeted therapy, is a monoclonal antibody, ramucirumab, REACH trial showed no difference between ramucirumab and sorafenib, but they found that for patients with alpha-fetoprotein higher than 4 milligrams per milliliter, they found a better overall survival. As you can see, that the median overall survival was 7.8 months. So they continue REACH1 with REACH2 only on patients with alpha-fetoprotein higher than 400 milligram, and they found the same results. It is an anti-VEGF drug, so we have the same toxicity as an anti-VEGF drug: hypertension, bleeding, proteinuria, arterial and venous thromboembolic events, GI perforation, fistula, and hepatic encephalopathy. So where it could be this drug after TKI, or if the patient don't tolerate the TKI, or if the patient has a contraindication to TKI. And some words about immunotherapy. What targets are in ACC? Cytotoxic T, lymphocytic protein 4, CTLA4, programmed cell death protein PD1, lymphocyte activation gene LAX3, B and T lymphocyte attenuator, and T cell immunoglobulin and mucin domain containing TIM3. How immunogenic is ACC? In this table, where they found some somatic mutation across human cancer, you can see that liver cancer is not very immunogenic, it's somewhere in the middle. The first anti-PD-1 utilized in the trial in advanced HCC previously treated with sorafenib was pembrolizumab. In this first trial, a phase 2 trial, where the patient, the characteristic of the patient you can see in this slide, 21 was HBV with HBV infection, 26 with HCV infection, and more than 90% of patients had child A, and 80% had progression on sorafenib, and approximately 3/4 had extrahepatic disease. I have to say that it is a very important response. The very short median time to response for this drug, 2 months, and for responder, 94% of responders were estimated to have a response duration higher than 6 months. And PFX of progression-free survival of 6 months was more than 43%, and the overall survival at 6 months approximately 78%. They tried to calculate, to analyze the result after immune-related RECIST criteria and RECIST 1.1. And they found that for immune-related RECIST criteria, PFS was 7 months and overall survival 12.9 months. Regarding the toxicity, as you can see in the slide, the toxicity is very low. Grade 3, the patient had in a few patients adrenal insufficiency, rash, and so after these results, after this phase 2 trial, FDA approved pembrolizumab in November 2018 for patients with HCC who previously was treated with sorafenib. So, but after this, they tried to confirm these results in a phase 3 trial, Keynote 240, for the same patients, for the same cohort of patients, which progressed on sorafenib, compared pembrolizumab with a placebo. But unfortunately, 2 weeks ago, they said that pembrolizumab fails to have positive results. Pembrolizumab showed an overall survival higher than placebo, but not statistically significant, and the same improvement in progression-free survival, not statistically significant. In the same time, in Asia Pacific, in Asia patients, is another Keynote 394 is ongoing. Another checkpoint inhibitor is nivolumab, and nivolumab for patients in advanced HCC patient was treated in Checkmate 040 in 2 expansion phase cohort of the trial, phase of escalation and phase of expansion. In first escalation dose, they found MTD, maximum tolerated dose, of 3 milligram per kilogram, and they used this dose for dose expansion and for patient in first line of therapy and in second line of therapy for patient with HCV infection and HBV infection. These are the baseline characteristic of the patient. I have to say that the patient, approximately 3/4 of the patient had advanced disease, metastatic disease with extrahepatic disease, and sorafenib was administered before this trial approximately 1 year in escalated cohort and in exposed was approximately 4 years. Regarding the rate of response, the patient had a very good rate of response on nivolumab, 54% in sorafenib naive patient and 55% in all sorafenib experienced patients. They found that the expression of PD-L1 receptor don't influence so much the rate of response. So it was not so good to be as a biomarker for the results of treatment with nivolumab. For patients with sorafenib naive, median overall survival was higher than 28 months, and for patients with sorafenib experience, approximately 16 months. As adverse events, as you can see, the data, the toxicity was very low, only low increase of transaminases and amylase and lipase. I think this data, this graph, show very well the comparison between PFS in second line between everolimus, brivanib, regorafenib, ramucirumab. These are the blue line, and these are the results for nivolumab. It's approximately double the PFS for nivolumab. So we are eagerly awaiting the results of these trials, this phase 3 trial in first line of therapy for advanced HCC. And about some words about combination and why we utilize combination, because it's a synergy between different combinations, systemic therapy and immunotherapy, local regional therapy and immunotherapy, and of course the combination between different immunotherapy, inhibitor of CTLA4, inhibitor of PD-1 to increase the rate of response. And why to combine this therapy? Because the targeted therapy could increase hypoxia, could increase the number of lymphocyte T regulator, could increase the expression of PD-L1 receptor. And localized therapy had a very important role in the increase the antigen load, and so the tumor could be destroyed by lymphocytes T. So the first trial were inhibitor of PD-1 and CTL1 in a phase 1 trial show good results. So we are waiting the results for Himalaya trial in which durvalumab plus tremelimumab is compared with sorafenib in first line trial, and lenvatinib plus pembrolizumab in 30 patients treated in this phase 1 trial show for these 30 patients very good results. 1 complete response, 10 partial response, and 15 patients with stable disease. But as you can see, the toxicity in the left side of the in the left side of the slide, it is very important. I think there are a lot of work for combination. As you can see, there are ongoing trials, regorafenib plus pembro, cabozantinib and nivolumab, ramucirumab and durvalumab. And atezolizumab plus bevacizumab was administered in a basket of trial: gastric cancer, pancreatic cancer, esophageal cancer, and patient with unresectable and advanced HCC. And they found, as you can see here, one complete response and 30 partial response and 45 patients with stable disease. And of course, with some better results for patients with HCV infection and better results for patients with without extrahepatic disease and macrovascular invasion. This trial, I think, is very important. Cabozantinib plus atezolizumab versus sorafenib could change the standard of care of patients with advanced disease for this type of therapy. As I discussed before, the adverse events for immunotherapy are completely different as we know until now. There are autoimmune hepatitis, there are nephritis, there are hypophysitis, thyroiditis, type 1 diabetes, pneumonitis. We had very aggressive pneumonitis until now for our patient. And I want to say 2 words about combination of TACE and sorafenib. As you know, before this trial, before tactics trials presented last year at ASCO, we had only negative results for association between sorafenib and TACE. And now this is the first trials with good results, but they found another important endpoint of this trial, which was untreatable progression. And so the patient treated with the combination has a median time to untreatable progression for 26 months compared with 20 months for the patient only with TACE, and time to progression of 24 months for combination and 30 months for TACE alone. This trial is ongoing. Association between sorafenib and Sirtec treatment, and the treatment, the adjuvant immunotherapy after ablation in this trial show very good results, and I think this could have very good results for association between TACE and nivolumab, sequentially interrupted or continuous. As a conclusion, I have to say that at the end of 2018, at first-line therapy, we have 2 drugs, 2 players, sorafenib and lenvatinib, and in second line, regorafenib, cabozantinib, ramucirumab, nivolumab, and pembrolizumab. Thank you very much.
Thank you very much for your presentation. Due to time, we need to move forward.
Okay. Well, next speaker is Professor Zenos Pârchies from Cluj-Napoca, improving screening in hepatocellular carcinoma.
Good afternoon, everybody. First of all, I want to thank the organizer for inviting me here. My topic today will be regarding the screening in hepatocellular carcinoma, and mostly how can we improve that. So we all know that hepatocellular carcinoma is arising mostly on patients with liver cirrhosis. It's a tumor where we know what is causing this tumor, and of course there are several etiologies for liver cirrhosis, and these etiologies are very different among different parts of the world. What is also the truth today is the fact that the incidence is increasing. It's increasing a lot due on one hand, due to chronic viral infections, and on the other hand, and this is mostly true in United States due to the lifestyle-related risk factors, namely NFLD. And we have a lot of causes, and due to this increasing in the incidence, we have to act more aggressively to detect more cases and to treat them accordingly. So you have here on this slide the natural way from a normal hepatocytes to the liver cancer, the first one, or the recurrence. And here we can place HCC screening on this road in order to detect those tumors in patients exposed at risk. What is surveillance? We know that the surveillance has its utility and applicability, and this is influenced by several factors. What is important is the incidence of HCC in the target population. So it's not the same to do surveillance where we have 0.5 incidence per year of HCC or where we have 3%. And second, the availability of efficient diagnostic tests at acceptable costs, and the availability of effectiveness of treatment. This is also very important because if you don't have the treatments, it's useless to do surveillance. And of course, we have to define the target population better in order to detect the incidence of HCC in the subsets of patients. We have, of course, in some subsets of patients, we have a higher mortality and higher rate of HCC, and that's why we need to act more aggressively. And when to do this, and which are the aim of doing surveillance? So we have to decide, based on cost effectiveness models, if we can assure an increase in life expectancy of at least 3 months with acceptable cost. And you have on these slides the value of $50,000, but there is very different. I have found $35,000 in some studies or $150,000. So with a certain cost. So this is the definition of surveillance. Of course, regarding the target groups, and you know everybody about that cirrhotic patients must be screened. One information is important here, that the incidence in that population should be at least 1% per year in order so that the surveillance may be effective. Otherwise, it's not effective if the incidence is below. And here we have, of course, patients with, regardless of etiology, patients with Child-Pugh A or B, and in Child-Pugh C, it's not worth to do surveillance unless you don't have liver transplantation in your unit. Of course, there are other groups of patients with hepatitis B. I will not go into detail, not cirrhotic patients. Of course, here we have to decide, and we have a good score which is, we can apply it in order to stratify the risk of the patients. And of course, we have other patients with advanced fibrosis, but not cirrhosis, where here also we have to screen the patient for the appearance of hepatocellular carcinoma. It was an interesting paper in abstract published in the American meeting last year of the study of the liver. And based on a lot of patients, it was demonstrated that the incidence in HCV is 3 times higher than the other etiologies, and this is very important. And the incidence has changed over time, so we have no more HCC than in comparison with 10 years ago or 15 years ago. And besides cirrhosis, okay, we have the population, we have the cirrhotic population, but even in that population, we have other independent predictors of HCC, which the most important are age and male sex, and of course other factors. In the NAFLD population or in patients with alcoholic liver cirrhosis, diabetes and body mass index are also associated with this. What about new target groups? I will speak briefly on NAFLD, on patients with HCV after successful eradication with these new drugs, and on patients with HBV, patients with cirrhosis due to HBV infections on treatment, which are for several years on treatment. Regarding on FLD, of course, what is important to know that half of the patients which have HCC do not have in fact cirrhosis. So that means that we have to screen also the patients without cirrhosis, which is almost impossible because the population is so large. We cannot screen all the obese patients. And of course, in that group, we have to define other risk factors in order to do a good screening. We have another challenge here due to obesity, because if the patient is obese, you cannot do ultrasound for screening. It's very difficult to do ultrasound in an obese patient with a very fatty liver. It's very difficult to find a nodule on that liver. And of course here, maybe CT or MRI will play a role. Regarding the patients with HBV-related cirrhosis, it's very interesting that the risk of developing HCC is decreasing from the first year of treatment, which is about 3.2. In the second, after 5 years of treatment, we have a decreased incidence on 1.57. But this incidence is above the threshold of 1.5, so it's worth to do, even after that, to do surveillance and in order to detect HCC. So we do not stop the surveillance in those patients. We have found a lot of HCC in patients on NUCs, which stopped the surveillance, which did not perform ultrasound. What about the surveillance test? Ultrasound, you know, it's accepted. It has a sensitivity in a wide range between 60 and 90% with a good specificity, but based on a meta-analysis, for all tumors, it has a good sensitivity, but if you consider only the early cases, you see that the sensitivity goes down to 60%. So we have a lot of limitations. It's very difficult to find a nodule in a very inhomogeneous liver. And of course, you need special training. The value of ultrasound is clear, very different among different hospitals and with different laboratories of ultrasound. Regarding tumoral markers, you have here a lot. In the beginning, alpha-fetoprotein was considered to be part of the screening program. Nowadays, it's considered not to be, because it adds only 6 to 8% of new cases is when you add alpha-fetoprotein to ultrasound. Why? Because it has a low specificity. If you consider the normal value of 10 microgram per liter, due to the inflammations and the flares of chronic viral hepatitis. But alpha-fetoprotein could be a valuable marker in patients treated by direct antiviral drugs, for example, in the population with HCV, because there we don't have inflammation, and maybe in that population, alpha-fetoprotein could have a higher role. Of course, the other dexcarboxyprothrombin, but it's not does not add much in comparison with alpha-fetoprotein. Very interesting new data comes on CT and MRI. Why? Because we know that it has a double lesion-based sensitivity for small HCC in comparison with ultrasound. But on the other hand, they are with higher cost and in case of CT with irradiations, and preclude their use as a practical widespread options for HCC screening. But in the new concept of personalized screening, those techniques may have a role. And I want to show you this new kind of MRI, which is less sophisticated MRI, which costs half the price. And it has high sensitivity and specificity, and as I will show you later, it is very cost-effective in detecting HCC in a special population of cirrhosis. Regarding screening interval, we all know 6 months it's stated. But if you use 3 months, it's no clinical benefit, although in some studies it was demonstrated that it could be cost-effective when the annual incidence of HCC is 3% or more. The 12 months, we detect fewer early stages with shorter survival. So you see the screening intervals among different societies, most of them have 6 months. But without with the exception of the Japanese society, no one stratified the risk of those patients. You see that in the Japanese society, the use of the screening methods, namely ultrasound, is stratified with the risk that the patient has. And here there is also a place. Can I go back? Okay, so here you see that there is also a role for CT and MRI. And I am sure that most of you, or some of you, are doing in the cirrhotic population, are doing one per year or 1 in 2 years a CT to a patient with liver cirrhosis in order to detect a nodule that was not seen by ultrasound. So which are the limitations of surveillance? To be effective, cost-effective, it should be available to more than 34% of patients at risk. The real world shows that it's not the fact. We have the utilization rate below 20%. So here there is a place where we can improve the surveillance. And on the other hand, we have a lot of patients with cirrhosis, and the target population is so big we cannot apply this surveillance method to all of them because it's impossible due to costs. And see, these are the uncertainties in surveillance strategies. In NFLD, we don't know when to do it, how to do it. There are others regarding patients with not a very good grade of recommendation and level of evidence for example, regarding the tumoral biomarkers. How we can improve the screening? Here you have 4 directions: to use the clinical HCC scores, to use the molecular HCC risk scores, to have an individual risk-based tailored HCC screening, and of course, to have to imply multi-level clinical and community-based interventions. About clinical risk score, you have here a lot of, it's a very busy slide, we don't try to find very valuable information there, but what I want to, among all of this, what is important to know is the detection and the evaluation of rigidity of the liver. It's very important because it will stratify, and most of the scores, or alone or in combination, will take into account this factor. And here you see on patients with hepatitis C, you have clearly the relationship between the rigidity of the liver and the risk of hepatocellular carcinoma. And this is also valid for patients with hepatitis B. So we can stratify very easy the risk and maybe to apply new rules in surveillance based on the detection of the rigidity of the liver. And this is also true for patients having been treated with DAA for HCC. And you see here that in multivariate analysis, a liver stiffness more than 30 kilopascal, it makes the patient at very high risk to develop hepatocellular carcinoma. And also in a very interesting paper published this year, we have here a lot of factors taken together, and the relationship between that factor and the risk of and the incidence of hepatocellular carcinoma. And you see, if we combine them, we have a very good method to detect the real risk in developing cancer. Regarding molecular scores, there are different and a lot of genes, enzymes, which could be detected and could give us a better way of understanding the risk of HCC. And last, individual risk-based tailored HCC screening, and this will enable a personalized screening in order to optimize the allocation of the medical resources and to maximize the cost effectiveness by tailoring intensity of screening and prioritizing a subset of patients with higher HCC risk for chemopreventive treatments. And here is a paper published in 2018, and here also imply what I have told you, the MRI, the abbreviated MRI in patients with liver cirrhosis at risk of developing HCC. And you see here that the risk stratified strategies, they applied only in moderate and high-risk patients MRI and compared them with the standard approach. And they demonstrated that this approach using MRI, which is more expensive than ultrasound, is cost-effective. And also a very nice study that was published in Hepatology 2019, where this MRI was shown to be cost-effective in patients with high risk of HCC, and it's a very important information and very important data that came out this year. Sorry. Okay, and this is also cost-effective. And what about the patients treated by DAA, the cirrhotic population or with advanced fibrosis? In a Markov model analysis, it was found that HCC surveillance is warranted only in patients with cirrhosis, and is cost-effective. In patients with F3 cirrhosis, F3 fibrosis is not. So to conclude, I put on this slide the EASL recommendation, which I have gone through almost all of that. And at the second part of conclusions, I have put these ways to improve screening, which implied the use of clinical HCC risk score, and the stiffness here is important. Don't forget you can stratify the risk of your patients by using this very valuable information. And now we have a lot of ultrasound machines which have the options to detect the liver stiffness. You don't have another machine. We don't need the FibroScan machine to assess the stiffness. And don't forget the MRI, this kind of MRI, which may be also very important in detecting HCC. Of course, the future will be probably related to molecular HCC risk score, and we have to imply this individual risk-based tailored HCC screening. What can the community and the healthcare perform is to imply new strategies and new rules in order to do this screening or surveillance in more population, and of course in this way to detect and to increase the detection of HCC. Thank you.
Maybe one short question or comment. Anyway, we are behind the schedule, therefore thank you very much.
Thank you.
It's my pleasure to introduce my co-chairperson, the distinguished Professor Susanne Beckebaum from Münster, Germany.
Diana, thank you very much for this very kind invitation to attend again at this very excellent course. I'm happy to be here in Bucharest. Thank you. Okay, so my topic is about liver transplantation for alcoholic liver disease. And we all know that until recently, liver transplantation for severe alcoholic hepatitis has been a contraindication in many transplant centers all over the world due to often not fulfilling the 6-month rule, due to public concerns, and also due to the limited organ donation pool. We know that alcoholic liver disease at itself in cirrhotic patients is one of the most common indications for liver transplantation in many transplant centers all over the world, but it is cirrhotic liver. And when you take a look at trends in etiologies leading to liver transplantation in Europe, considering ELTR data between the early 80s and 2016, you can see that 56% of patients are transplanted due to cirrhosis. And when you just consider cirrhotic patients, you can see that indication for alcoholic liver disease as primary indication or as secondary indication was approximately 40% during the last years. When we take a look at recent trends in the US for alcoholic hepatitis and transplantation, we can see that as in the European countries between 2002 and 2012, there was a quite stable number of transplants, whereas in 2013 and between 2013 and 2015, there was a certain increase by 4% that equals a total number or arose by 177 transplants. What about graft survival in patients with alcoholic liver disease? When we just focus on DIA error, taking into account SRTR data, we can see that graft survival in patients with alcoholic liver disease is similar to patients who are transplanted due to hepatitis C, and it is even better as compared to patients who are transplanted due to NASH-induced cirrhosis. First of all, we should also think about a diagnostic definition of a severe alcoholic hepatitis. And we know that it is a clinical entity. We have a certain definition of the Alcohol Consortium of the US, and it has been proposed that jaundice due to cholestatic hepatitis as well as decompensation are clinical signs of SAH. And there is not definitely a clear threshold when SAH can develop, but it has been assumed that more than 40 grams for women per day and more than 50 to 60 grams per day for men are certain amounts that develop disease progression. And usually, those patients who present with heavy alcohol consumption and SAH, they have not alcohol abstinence, or have a very short time period of being abstinence of less than 60 days. In the US, it is not very often that liver biopsies is performed in patients with severe alcoholic hepatitis. I think it can be useful in cases where the diagnosis is not certain. We usually do see neutrophils surrounding the dying hepatocytes. We'll see ballooning of hepatocytes. We see Mallory-Denk bodies, and usually there is some kind of fibrosis. In the majority of patients, more than 50%, there is already cirrhosis. When we ask us about pathophysiologic basis of ALD-induced ACLF, We all know that hepatic inflammation, as well as bacterial infection, as well as continuous alcohol consumption are precipitating factors of acute and chronic liver failure. And those patients who have developed cirrhosis, they are prone to bacterial infections due to defects in their innate immune system and adaptive immune system. And we know that molecules released by liver cell death, as well as bacterial products, that these trigger systemic inflammation, leading to a sensitization of the immune system and to acute and chronic liver failure. Just some words about directive German authorities and our guidelines, how to treat patients we want to treat with liver transplantation. Our German authorities say that patients with alcoholic-related liver diseases can only be transplanted in case of alcohol-induced liver cirrhosis, and if they have a sobriety of at least 6 months. This means that patients who have acute alcoholic hepatitis and just some kind of fibrosis, we do have a contraindication for liver transplantation so far. If there is a very, very urgent need for liver transplantation, the transplant conference of the corresponding center can deviate from this rule. And the transplant center can ask for an alcohol audit, and the Eurotransplant directs this alcohol audit. And there are usually 3 auditors. It's a hepatologist, it's a surgeon, and it's a mental health specialist who gives their expert opinion about this specific case. And the votum is only positive if all 3 auditors agree to an exceptional listing. Of note, you should be aware that finally not the 3 auditors and also not Eurotransplant decides if the patient is listed, but that the final decision, if to list or not to list the patient, relies on the transplant conference on the corresponding center. We have all heard about predictors of recurrence. I don't need to list them up, but I think we also know that psychosocial intervention is definitely necessary in the management of ALD patients prior to and after liver transplantation. And I just want to shortly talk about an alcohol addiction therapy. Dr. Erem is from the psychosomatic department of the University of Essen, and a lot of years ago we said and decided it is necessary to implement an alcohol addiction program in our transplant center. We are both not anymore in Essen, but the program still exists. And after gaining some experience, we did a study and included patients who were prior to liver transplantation. They needed to attend 12 sessions, and they were defined as completers if they attended at least 9 sessions. And you can see on the upper part of the slide that those who completed these sessions, that there was a significantly lower percentage of positive urine ETG samples as compared to those who dropped out. And also over time, the percentage of positive ETG samples decreased during the study period. So I think it is necessary to point out prior to liver transplantation on the waiting list, the patient needs monitoring, but this is also necessary after liver transplantation. There are several direct and indirect markers to measure alcohol consumptions. You see in the upper part direct markers which are not really very helpful. CDT, for example, is influenced by cirrhotic changes of the liver, by weight, by gender, and so on. And when you focus on direct alcohol markers, I think ETG, measurement in urine as well as measurement in hair, is quite quite sensible because it's highly reliable and can just be influenced by, for example, a urine ETG, by chemical treatment of the hair, or when you consider hair ETG, and when you consider urine ETG, it can be influenced by urine dilution or contamination of food. However, I think until now it's the most reliable marker. And we ask ourselves, okay, what is the problem with transplanting patients with acute alcoholic hepatitis? The reason is that there are some centers and opinions pro and some against liver transplantation for alcoholic hepatitis. Those who are against liver transplantation for this disease, they argue that after a certain time of abstinence, after 6 months, some patients do not need any liver transplantation anymore, and that it is also a negative public opinion which reduces the willingness for organ transplant, for donation. On the other hand, we do know that the 6 months rule is not evidence-based, and that also due to other diseases, for example, due to drug-induced viral hepatitis, as well as to NASH-induced cirrhosis due to overweight, it is a certain kind of behavior also in other diseases that leads to disease progression. There are different markers that are helpful to decide for us, hepatologists, clinicians, if to treat a patient with alcoholic hepatitis with steroids or not. And there is, for example, the metrodiscriminant function. We do have the Glasgow score, and we do have the Lille score to decide if we should proceed with steroids at day 7 after treatment. And also EASL clinical practice guidelines have a certain management algorithm how to deal with patients with acute alcohol hepatitis. As they say, in those cases where it is uncertain, you can do liver biopsy. For sure, you should screen the patient, you should screen him for infection, you do need to screen him for malnutrition, and at a certain MDF score or the Glasgow score, you can treat or should treat the patient with prednisone, and if the Lille score at day 7 is higher than 0.45 or is equal to 0.45, you need to consider liver transplantation, early transplantation in this patient. There are also different agents who are included within studies to treat a patient with alcoholic hepatitis. And there are some approaches who want to change the gut microbiome of the patients. There are those who have something to do with activation of FXR. There are some who want to have or who are supposed to have anti-inflammatory approach, or for example EGSF. We do know so far not if these agents are really of high beneficial for our patients, and we do need to gain more experience in these agents. We all know the study, the early liver transplant study for severe alcoholic hepatitis by Maturin. And we know that after the patient had a strict selection process, the survival of these patients who were selected for liver transplantation was good in the short and medium term after liver transplantation as compared to those who were not transplanted due to alcoholic hepatitis. And due to this experience, due to the Maturin study, AASLD guidelines said that in these exceptional cases and after selection process, those patients can be considered for liver transplantation, but that they definitely need to go an addiction rehabilitation program, and that these patients after liver transplantation do need a thorough aftercare and a counseling. And after publishing these AASLD practice guidelines, you can see on the right side of this slide, there was also a change in policy in many liver transplant centers in the US. You can see from 2014, there was a steady increase of liver transplant, of centers who did liver transplantation in this indication. This is an interesting study performed by the Dallas group. They did a web-based survey of liver transplantation practices for severe acute alcoholic hepatitis. And you can see in the lower part of the slide that at this time where the survey was performed, that from the centers who did do transplantation for SAH, and this was half of the centers, that nearly half of the centers had performed 1 to 2 liver transplantations. There were 1/3 of centers who had performed 3 to 5 liver transplantations, and there were less than 20% of centers who had done 6 liver transplantations or more. And when you take a look at those centers who did transplant this indication, whereas those who did not, you can see that the number of liver transplants per center, as well as graft survival or a MELT score, was not significantly different between those groups. And also the policy for listing liver transplant patients, the criteria for listing patients with alcoholic liver disease having cirrhosis was similar in both groups. It is not surprisingly that the study by Mathurin did influence French transplant centers. And would just shortly comment on this study by Antonini and co-workers. They did a survey, and you can see that before publishing the Mathurin study, there was just 1/3 of centers who did liver transplantation for this indication, whereas after or beginning from 2011, it was already 71% of centers who did this transplantation for this kind of disease. And in 2019, we nearly have 100% of centers who perform liver transplantation due to SAH in France. After publishing the AASLD guidelines, European guidelines were published later in 2018, but they are similar to AASLD guidelines, and they also point out the thorough examination and monitoring of the patient before and after liver transplantation with alcohol-related liver disease, and to definitely implement a multidisciplinary approach and to have an addiction specialist within the multidisciplinary team. So what about the outcome and prediction of risk for sustained alcohol use after liver transplantation? This is a recently published a study by the American Consortium of Early Liver Transplantation for Alcoholic Hepatitis, performing the so-called Accelerate Acute Alcoholic Hepatitis study, including 12 centers from 8 UNOS regions. And early liver transplantation was performed in 147 patients. And you can see that there were excellent survival rates, 94% after 1 year and 84% after 3 years. And when you take a look at sustained alcohol use after liver transplantation, you can see it was 10% in the short-term period and 17% in the medium term after liver transplantation. When we consider any alcohol consumption, means also patients with binge drinking, patients who have slips after liver transplantation, the recurrence rate was 25% after 1 year and 34% after 3 years. And of note, those patients who had recurrent alcohol consumption, the survival rate was significantly lower as compared to those who were abstinent to alcohol. There are also some prognostic instruments published in literature monitoring alcohol, or the risk of patients having alcohol consumption recurrence after liver transplantation. There is one transplant assessment, but until now there has not been an assessment score specifically developed for liver transplanted patients. So the group by Lee and co-workers from San Francisco, they performed a study and tried to determine factors for recurrent alcohol consumption after liver transplantation. And they found that an age lower than 48.5% was associated with a higher risk of any alcohol consumption after liver transplantation, and that variables for sustained alcohol use after liver transplantation was more than 10, was high drinking at presentation, more than 10 drinks, at least one prior rehabilitation attempt that failed, and any history of alcohol-related legal issues, as well as a history of non-TLC illicit substance abuse. And having these factors, they created a score. And this score is not so helpful in determining patients who have a high risk. It's much more helpful to identify those patients who have a risk for lower than 5, because this means these are the patients who have a low risk of sustained alcohol use after liver transplantation. This is a study also performed by Lee and co-workers, and just to shortly go over it, he compared those patients with alcoholic hepatitis, whereas those with alcoholic cirrhosis having more than 6 months of sobriety. And he compared survival and recurrent alcohol consumption, and he did find that both factors, survival and recurrent alcohol consumption, was not significantly different in both groups. Of note, heavy alcohol consumption was more often in patients who had alcoholic hepatitis. However, this difference was not statistically significant. Recently, it has been published a study, a systematic review with meta-analysis by a Swiss-Belgium group. You see, there were a lot of studies available in literature. At the end, they just extracted 11 valuable studies. But when you take a look at the studies, you can see that there is just one study who has a prospective design. You do see there are very small cohorts, and also the definition for recurrent alcohol consumption was different in the various studies. However, these meta-analyses found that the pool estimated risk for alcohol relapse, as well as the 6-month survival, was not significantly different between patients with alcoholic hepatitis and those with alcoholic cirrhosis with 6 months or longer of sobriety. And at the end, I would just like to mention that we should be aware that those patients who are transplanted for alcohol-related liver disease, that those have a higher risk of de novo tumor recurrence and cardiovascular complications as compared to other indications for liver transplantation. This has been shown in this ELTR study, but also in many other studies. And due to this, it is necessary that these patients with alcoholic liver disease, no matter if they had cirrhosis at transplantation or just acute alcoholic hepatitis with fibrosis, they need an intense surveillance protocol. They do need annual skin and ENT examination and some kind of chest and abdominal imaging. And they need to be informed about lifestyle changes. They need to get rid of cigarette smoking. And it has also been discussed if these patients should get a different immunosuppressive regimens than other patients. Means to minimize CNI and probably to go to switch to mTOR inhibitors. But we do need prospective studies, and we don't know clearly so far. So in conclusion, the success of the Maturin study, which has been followed by several retrospective studies and data analysis, represented a definite paradigm shift in therapy for highly selected patients with SAH who are not responding to medical therapy. However, we have a lack of prospective study. We urgently do need them, and we need to define more precisely the criteria for selection of those patients with SAH, and we definitely need more information about long-term outcome of these patients. Thank you very much.
Thank you very much, Professor Beckebaum, for this excellent presentation in such a sensitive and controversial issue, I would say.
Yes.
If there are questions or comments.
I know that I have heard from you and from Speranza that the that the policy is a little similar to the German policy, so that you, in Romania, you also transplant more patients who are on cirrhosis. So this was interesting for me.
Yeah, thank you for the comment. Actually, you have to adjust the donor pool that you have to the social, I would say, requirements of the population, and therefore, honestly, this is not a very good indication, I would say. Well, so this presentation is closing the session, and thank you very much for your kind attention.
Hello. Even if it was you are a little bit tired, and then the session was so interesting and difficult regarding transplantation and cancer. We'll continue. And it's an honor and a pleasure for me to introduce the next speaker and prominent in public health expert, and especially on viral hepatitis elimination, Professor Lazarus. He will present persisting gap on the road of elimination of hepatitis C. Please, Professor Lazarus.
Thank you very much, Dr. Pop, for the introduction, and thank you very much to the organizers for the opportunity to be here today. This presentation will be a bit different than the others I heard. It will be less clinical, although I think I will present some issues that are important for your clinical practice. In general, I'll be focusing on health systems, health policy, models of care, and this new wave of energy moving through Europe and around the world to finally be able to talk about the elimination of hepatitis C. My background is I spent over 11 years at the World Health Organization before moving to the university, where we set up a WHO collaborating center on HIV and viral hepatitis. And back when I was at WHO in 2006, we were desperate to get hepatitis C onto the agenda, because hepatitis B was, of course, being addressed through the Vaccine Preventable Infections Program. So we made these small magnifying glasses. I'm not reaching for my phone, I was reaching for my wallet. And we would put them in our wallets and take them out at meetings, and you would look through it and say, well, where is hepatitis C in the policy documents? Why is no one at WHO working on hepatitis C? Where are the patients? And so many other questions. And it says 2006, get tested. And I think here in 2019, we still have the problem of finding those who are undiagnosed. Now that we have the effective treatments in hand, it's much easier to screen and encourage testing, something that wasn't so different back 13 years ago. So let me talk about some of the gaps we still have in a moment when treatment is highly effective and increasingly widely available. These are my disclosures. Mostly I've received support from the people outside who are producing the medicines, allowing me to travel around and research in this field. Our goals at this moment are extremely aligned. We want people to be able to access the effective treatment at reasonable prices. Now, a couple of questions for you to be thinking about during this talk and as we move ahead along the road to elimination. One is, do you think that the elimination of hepatitis C as a major public health threat is possible globally, and is it possible in Romania by 2030? That's the WHO goal, and that's the goal that the Minister of Health of Romania adopted in May 2016. So we have the policy documents in hand finally. In which specific populations do you think we can eliminate hepatitis C already now? And I'll explain the concept of microelimination and how we can start to focus in certain geographic regions and in certain populations so we can achieve elimination in those groups and in those areas ahead of 2013. And really the big question right now in the field of hepatitis C, this is a very different presentation than at your previous updates, where you would have had presentations about sustained virologic response, the response in certain genotypes to certain medicines. As we know now, that is slowly a thing of the past with highly effective medicines with SVR rates of over 95%. So the question we want to be thinking about is how do we translate these good biomedical tools into good health outcomes for people living with hepatitis C? So we already know about the DAA breakthrough. You're all experts in the field, so we don't really need to spend time talking about that. We know that in 8 to 12 weeks with a pill once or multiple pills during the day, highly tolerable, we are most likely, if the patient adheres, to achieve elimination. Instead, the challenge is really one of public health. It's a question of access. It's a question of coverage. And in some settings, it's also a question of quality or safety. I'm not sure that's so much the issue here in Romania. You can let me know during the discussion. But in some countries with parallel importation or with unsafe drug supplies, this can be an issue. It can also be an issue related to prevention, where you have harm reduction services, and due to the criminalization of certain behaviors, you might have people going to get their clean needles and syringes, and in turn being arrested by the police, as we have in some countries, or you may even have attacks on low-threshold centers, like what happened recently in Athens, Georgia. Greece, Athens, Georgia. There is an Athens, Georgia, but that's not what I was referring to. So instead, achieving a sustained virologic response in everyone with HCV requires much greater attention to health systems challenges to resolve these public health issues. And so, like I said, we really don't need to go through the issues around the medications. We are in what we would call the elimination era. We have 3 main treatment regimens, 2 of which are pangenotypic. So we have now a new global political will to eliminate hepatitis C. When I was at WHO, as I pulled out the magnifying glass, we really didn't have policy documents in place to allow us to address hepatitis C, which in turn made it difficult in many countries to address hepatitis C. In 2014, the World Health Assembly approves its 2nd resolution on viral hepatitis. It calls on all countries to develop a viral hepatitis strategy, and for WHO itself to develop a strategy. The next year, the patient groups of the world meet for the very first time. They met in Scotland together with WHO, the government of Scotland, and many political representatives from around the world. It's very nice to see the Romanian patient representative here in the audience. And this meeting was about putting patients in the center. You clinicians weren't really allowed in the door the way it was at the International Liver Congress for patients in the early days. Of course, everyone was allowed in, but it just wasn't so interesting. This was an opportunity now for the patients to share their experiences and talk about how they can start to access what they were calling a real miracle cure. No more PEG interferon with a ribavirin booster. Now they could take all orals. And in 2016, in February, and I know that you were there, Dr. Pop, maybe others as well, for the first time, elimination got onto the EU agenda when experts, including clinicians, researchers, policymakers, including the European Commissioner for Health, Dr. Andriukaitis, and patients, met in Brussels and released the first elimination manifesto calling on the EU to support elimination. 4 months later, WHO adopts its first strategy on viral hepatitis, and they called it the Global Health Sector Strategy on Viral Hepatitis, recognizing that this was not an infection or set of infections that we would eliminate in isolation, but the entire health sector had to work together. And they called for the elimination of hepatitis as a public health threat. So with my PhD in public health, I started thinking, well, how are they defining public health? You know, when you get a group of public health experts in the room, everyone will have a different definition about what public health is. What WHO did was set this series of targets and say, by achieving these targets, you've achieved elimination. There are more targets, but here are the HCV targets at a glance. There are incidence targets that already need to be met by 2020, and then the overall targets for 2030. Mortality targets, testing and treatment targets, and importantly, I think, harm reduction targets, which I know is a real challenge here in Romania. Here, the focus in the viral hepatitis strategy is on needle and syringe exchange, and of course, we know the comprehensive package of harm reduction includes opioid substitution therapy and many other interventions in order to provide harm reduction to people who inject drugs, the population currently most affected by viral hepatitis in most European countries. Here are just a couple slides with data from the European Monitoring Center on Drugs and Drug Addiction, the EMCDDA. Not that we have the data available on Romania, but you can see the number of syringes provided per person who injects. So the baseline was 20. The goal is 200, and we know that for people who inject drugs, many of them will inject multiple times a day. So even 200 needles and syringes a year distributed is not enough. But here you can see that most countries are not doing well in terms of needle and syringe distribution, and I think that's also the case in Romania, and you can correct me if I am wrong. In terms of opioid substitution therapy, generally countries are doing better. There are buprenorphine and methadone countries in almost all EU countries, and the question becomes what is the coverage, how well are they accessed, are they made available in prison settings, and so on. And you can turn to the EMCDDA's website, put in your country, pull up this data, compare with other countries, and I won't spend more time on this right now, other than to say that when I come back to the issue of micro-elimination, one of the places I think we should rather easily be able to eliminate hepatitis C is in people who inject drugs that are on opioid substitution therapy. They're already coming in to get their medications every day or almost every day of the week, so it should be quite easy to offer them a hepatitis C test, and if positive, provide the medication to them. It's another question of whether you're allowed to provide the medication at those centers, who's allowed to prescribe, some of these health systems barriers that I'll address later in this talk. So WHO, in their strategy in 2016, put forward this organizing scheme, the continuum of viral hepatitis services and the retention cascade. So the WHO goal, as I mentioned, is to eliminate HCV as a public health threat by 2030. And what this cascade of care can help us do is monitor progress. So we would see on the far left the prevalence of everyone infected. Many countries do not have good prevalence data, but you might have this at a smaller level, at the city, at a region, or even at your particular hospital or clinic or department. And then the question is, how many of those you think are infected have been tested? And how many of them are aware of their diagnosis? We know that many people diagnosed many years ago have been lost to follow-up. They were deemed treatment eligible, or for some other reason were lost in the system. And this is a real challenge we're facing in Western European countries. In Denmark, in Norway, and the Netherlands, we know that thousands of people have been diagnosed, and now it's a question of how the system can identify them. Should it be the general practitioner? Should it be the hospital? And how does one operationally make that happen? And as you progress through this cascade of care, to linkage to care, to treatment, and ultimately cure, you start to see a drop-off. We lose patients along the way. One of the biggest challenges is in getting people diagnosed, but another challenge is linking them to care. We know now that most people treated will be cured, which is exciting news for us in the field. And finally, WHO added in follow-up chronic care. So the story is not over just with SVR. If your patient presented late, you need to continue monitoring them at whatever interval your guidelines will tell you that makes most sense, and it will depend on the degree of fibrosis at which they presented. So one of the innovations I wanted to present, and this is just ahead of the International Liver Congress where we'll present it again, I hope they don't mind, is that WHO continuum of care is quite challenging for many countries to complete. So just like in the field of HIV, where there's a long continuum of care and then a focus on just 3 points, what's called the 390s, we've put together a consensus hepatitis C continuum of care, where we ask countries to at least be able to report on the number estimated to be infected, the number diagnosed, the number treated, and the number cured. And probably through time, we won't even need to report on the number of cured, because as we often lose, or sometimes lose people to SVR12, we know that if they did complete their treatment and they did have SVR at end of treatment, they will most likely have a permanent SVR. But we are asking countries to report the numbers infected, the numbers diagnosed, the numbers treated. WHO, the ECDC, the European Centers for Disease Control, has reached out to all member states, asking them to provide many more details. That will be challenging for some countries. I hope all countries will be able to report everything that's being asked, but at a minimum, we think this is what countries should be able to report, and you should know this information at the clinics, the hospitals, the centers you work in, because it will guide your intervention, especially if you start to stratify it by mode of transmission. It can also help you think about, where to invest your resources. So as you start to know that information, and this is an exercise we carried out last year at what was called the Screening and Linkage to Care Summit with around 250 experts from around Europe and abroad. We took a look at the continuum of care and asked them in different country groups, where would you invest? And what was interesting here was the heterogeneity of the response. You know, some countries felt we really had to do more about linkage to care, or we really had to do more about screening and diagnosis. Well, for us researchers, there was a lot less of an interest in surveillance and epidemiology and even researching some of the public health interventions in some of the countries. But it just shows you how each country will have to formulate their response differently, and the overall guiding strategy, the overall guiding document for your response should be the WHO strategy and hopefully a national strategy or a national action plan, if you have one. Is there one in Romania right now? A national viral hepatitis strategy? I know there are clinical guidelines. I'm not aware of there being a strategy. I do think it is important if we're going to at least a short document at the national level to guide the activities, and then of course one needs something more operational, but that's different than your clinical guidelines, which tells you what to do when you actually have the patients. So many of the issues I've been raising are really health systems issues, and sometimes we can feel, oh, the health system, so difficult to change, but I know that some of you in the room are very active and have important roles in the health system, and health systems planners often listen to the clinicians. So you have a unique opportunity to talk about how will we in Romania implement this WHO strategy, and in turn the WHO European Action Plan that was approved in September of 2016. So here you see WHO defines the health system as focusing on really 6 main areas: service delivery, the health workforce, information, medical products and technologies, financing and leadership and governance. And then they have these 4 interim goals, which I already mentioned, but the goals of access, coverage, quality, and safety, and ultimately the goal of any health system, which is improved health. And you'll see that WHO puts this in parentheses, level and equity. So it means not just achieving those targets I mentioned at the beginning, but doing so in an equitable fashion, which means that if some groups are not reaching those targets, we really can't say that we've eliminated viral hepatitis C. And that means reaching out to people who inject drugs, migrant populations, prisoners, and other groups that might be left behind, marginalized, or disproportionately affected by the epidemic. So in 2014, feeling that this image here was a little bit dry, a group of us working at Health Systems Global added some color, rejigged the health systems framework a little bit, and added in the important role of communication between all parts of the health system and patient engagement. In fact, it shouldn't just be patient engagement, it should be engagement with all groups at risk of contracting and transmitting hepatitis C, to show really the interaction we need to have within the health system and the new kinds of models of care that we're going to need as we move forward. WHO, a few years later, launched what they call a people-centered approach to health systems. This is how they portray it, with people in the center. And you see here the different parts of the health system around the person to show the dynamic interaction of the health system, always thinking about the person who needs prevention or who needs treatment or who needs care. So a question for you. If you were someone who injects drugs, and you were attending here a drug treatment unit, an addiction center, a drug and alcohol center, and you heard about this hepatitis C infection, where would you want to get tested? Where would you want to get treated? Well, we asked these drug users, and they said, well, it would be really nice if we could just do this right here at the drug treatment unit, because we really don't have time to go somewhere else, and it can be quite challenging for us to get to these other locations because of the costs, because of the opening times. So on the left, you see the former organization of the health system, quite simplified in this drawing, in Copenhagen. As a part of this shared addiction Copenhagen program called SAC, Shared Addiction Care Copenhagen, we removed the role of the lab, allowing for testing to take place at the drug treatment center. We reduced the role, but didn't remove the role, of specialized care. And what we did was allow for the testing to happen at the addiction center, and if positive, the results were sent to the hospital. In turn, a hospital department nurse from hepatology or infectious diseases would go to the drug addiction center with the portable FibroScan, run the necessary tests, and provide the medicines on site at the addiction center if needed. That's a lot easier now when we're talking about boxes of pills and not weekly injections. So this is a system that might not work everywhere, but it worked well in Copenhagen. It took a long time to put in place because the IT system needs to talk. There's issues around reimbursement. There are increased responsibilities for those at the addiction center. And then the big challenge was getting those medications out of the hospital pharmacy, but not in the hands of a patient, because our hospital pharmacies aren't used to, they're used to receiving the medicines, they're not used to sending them somewhere else. So those are some of the sort of barriers we had to address. They sound simple, but they were quite challenging to get in place. And now we have this sort of test and treat system set up for people who inject drugs in addiction centers. But that begs the question of who should we treat for hepatitis C? This was some work developed by Jason Grebely and colleagues back in 2013. When the DAAs were coming out, it became very obvious that we treat those who are sickest. We treat the F3 and the F4 cases. Many of them are identified. Many of them are in hospital. That's who we treat. The question is, where do we go next? And many countries said, well, we start to move to the left. So then we would treat the F2 cases because they are the cases that would likely progress to F3 and F4. Others were saying, well, this is a bit of the leaky bucket syndrome. If we don't treat those who are continuing to transmit hepatitis C, we're going to keep having new cases. So really we should treat people who inject drugs, and in particular, even active drug users, not to mention those at opioid substitution therapy. And you can imagine the response from the authorities. It's, well, we're not going to treat people who are actively injecting drugs because they're drug users. A lot of challenges to overcome that, including many important studies that showed that they can adhere, that they want to be cured of their hepatitis C, and it will reduce onward transmission, just as we know in the case of HIV and really any other infectious disease. If you don't have it, you can't transmit it. And then the question was, well, we can't really leave out everyone in the middle, so the public health approach for elimination is to treat everyone. However, there are many barriers to do this. In many countries, there have been a minimum fibrosis stage required for reimbursement of DAAs. This map, which we first developed in 2017 and presented at the ILC, later published in Lancet GastroHep and in the Journal of Hepatology with various updates, shows the panorama where a lot of Western and Southern Europe did not have reimbursement restrictions, which means clinicians, if they wanted to, could prescribe. In other parts of Europe, there were reimbursement restrictions. Since November 2017, Belgium, Denmark, Finland, Israel, Luxembourg, Scotland, Sweden, all removed their restrictions. Now the majority of EU countries do not have fibrosis stage restrictions. Some still do. You can see this map is a little old. I can't keep changing the colors. Luckily, things are moving quickly. It was the 1st of November that the restrictions were removed in Denmark, and the 1st of January that they were removed in Belgium. And this creates a whole new panorama for us. Doctors can prescribe when they feel the need to prescribe. Another barrier to elimination that we're facing is late presentation. among people who inject drugs, but also among really anyone else. So we have a consensus paper that came out in 2017. You'll be familiar with some of the authors and groups, together with the European Association for the Study of the Liver. There's a long definition, but the short definition is essentially that if you're presenting with F3 and F4 upon first diagnosis, you're presenting late. And I'm sure some of you have diagnosed people who presented with F3 and F4, and there's nothing more disappointing than when your patient already has advanced fibrosis. So we encourage countries to map the situation, to set the benchmark with last year, like we're doing in Spain at 10 different hospitals, and to look each year at how many people are presenting late with viral hepatitis C or also B, who they are stratified by sex, by mode of transmission, where they were referred to from, so we can start to understand the situation and work harder to eliminate late presentation as a part of our efforts to eliminate viral hepatitis C overall. And another challenge is the limited treater pool. So we know that in a country like Australia, almost anyone can prescribe DAAs, and in almost all EU countries, this is limited to specialists. In some countries, it's only hepatologists. In some countries, it's hepatologists, GE, infectious disease doctors. And in England and Germany, even GPs can prescribe, although that is not very often the case. So, when I discuss this with experts, they say, well, maybe in our country we don't need to expand the treater pool. That was the case in Denmark, where we continue the prescribing from specialists at the hospital, but in this case, the patients don't need to go there. It was the case in a prison in Spain, where through telemedicine, the hepatologist continues to prescribe, but he or she does not actually have to go to the prison to do so. So we're starting to look at new models of care, and I think this will start to be the case in Romania, where you'll play an important, completely new role, in which case you'll be prescribing medicines for patients you might never have actually met in person. So, some of these challenges we're facing for HCV assessment and treatment are related to many hospital clinics for the patients and the costs of traveling to hospital appointments, and for them, the inconvenience of appointments. It can be very difficult if you have multiple appointments in one day, if you have appointments very early in the morning, or if it's difficult to reach the hospital because you live in a rural setting or you live on the other side of the city. And some of the solutions we've been discussing have been to include, to allow for specialized nurses to play a greater role, to look at what kinds of partnerships and outreach hepatology services can be implemented. In one of the hospitals I work at in Spain, the chief hepatologist takes the FibroScan, goes to the addiction centers. In other places, they simply loan the FibroScan, and that's done on site without the hepatologist involved. And also the important role of peers, something I'm sure your patient organizations have talked about, where buddying systems can help people get to appointments. We're doing this in Copenhagen, where we've launched a van where you can get tested and treated in a van parked behind the main train station. The doctor in charge never needs to go there. She's the head of the Clinical Society for Infectious Diseases, so a very serious leading doctor in the country. Her nurse can go check the testing results, take the medicines there. But if the patient does want to go to hospital, peers, in this case other people who are typically former injecting drug users, will take the patient to the hospital and help them through the process at the hospital, which can be quite challenging for them. So, elimination can be quite daunting. You see this WHO strategy and you're thinking, impossible in my country. And when WHO launched the strategy, there were some calculations that showed at the current price of treatment back then, it would be extremely expensive and not feasible for countries to eliminate. Those prices of medicines have fallen greatly in most countries, but it could also be a very complex situation. Suddenly, hepatologists are talking to prison medical officers. ID doctors are going to addiction centers. Drugs are moving back and forth with nurses and other healthcare professionals, and even sent in taxis to get to where the patients are. So all of this led us at the EASL International Liver Foundation, where I sit as vice chair, to develop a concept we call microelimination. The idea is not to seek full elimination in the population, but instead to start to focus on certain populations. So I asked this question in the beginning: which populations do you think you can already eliminate hepatitis in now? So patients with hemophilia, that should be quite easy. It's a low number of co-infected. Slovenia, Ireland, a few countries have done this, and it's been big news because it's the first time they were able to eliminate there. Nephrologists have gotten involved and said, we want to eliminate our patients on dialysis. I know Dr. Maticic and others have presented that this has happened, and it's been remarkable to see the look on their face when they say, well, we don't have this issue anymore. Decompensated cirrhotics. You can start to use this as a sort of organizing tool and say, well, we don't have this problem at our hospital anymore. We don't have this problem maybe in our country anymore. People who inject drugs is a challenging population, but those on OST are easier to diagnose and reach. People co-infected with HIV who are on antiretroviral therapy, we should eliminate in this population because they're already in our care, they're already receiving medications that they need to take every day, so they should be offered a test and treated. So population by population, you can start with the easiest, but our idea is to tick off these boxes so year after year we can come back and say, this is where we need to focus our efforts. I won't go through sort of all the academic work we've done around microelimination. I'll just highlight that when you're working on microelimination, you want to make some sort of a plan that would involve key stakeholders, that would involve developing simple but annual targets, and that would bring together patients, the other healthcare professionals that are relevant, the city, hospital, national planners, and that you need to monitor and evaluate how you are doing. It's not enough just to develop this plan, but we want to come back and see how we're doing. Hopefully you can publish your results. Even in our hospital, in a single site study we published in the National Spanish GE journal, that we've eliminated in the nephrology department, we've eliminated hepatitis C. So this is still news in our countries, even if the numbers are quite low, and it frees up those resources to then look at who we need to address next. So after we've eliminated in our hospital the patients on dialysis, of course the most serious patients in our care, those co-infected with HIV, the hepatology department made their first field visit out to the harm reduction center and said, well, what can we do here? And we set up with a gene expert, point of care testing, and when positive, the medicines flow with the nurse there, and the people who inject drugs never need to actually come to the hospital. The hepatologists don't need to go there, and yet we're moving quickly towards elimination in that setting in Barcelona. So how's the world doing? Well, there's about 194 WHO member states. 12 countries are said to be on track to achieving elimination. 3 more than last year, so that's a great increase in terms of percent, but we're still not doing very well. And this map is developed by the Polaris Observatory, and it's largely based on treatment figures, treatment percentages. We know that if we are going to eliminate, we need to have the full package of targets met, and that includes prevention, proper linkage to care, treatment, prevention of reinfection, and even ongoing monitoring of those who presented late. So let me end by just saying I look forward to the discussion. I think Romania has a chance to join the party, to move into yellow, move into green. So it's really up to you, because I'm leaving in a few hours. But I know you have another meeting coming up later this month where you'll have all stakeholders together. We have the International Liver Congress next month, and I know you'll have your regular updates, but I really hope that you'll take on board this elimination agenda and see how you as clinicians and others working in hospitals and centers can help us eliminate hepatitis C globally and here in Romania. Thank you very much.
Thank you, Professor Lazarus, for this very nice and comprehensive presentation and very interesting. Before I invite Professor Gheorghe to answer to one of the questions, I have to say that we have approved a national plan on December, and I think that next month, on 14th of May, we'll launch officially the national plan, and I think that we are already on yellow. We are not yet in red on your map. Please, Professor Georgi, if you want to answer and to comment, to make some comments.
But I don't think I have the answer in this regard, but what is true actually is that we make efforts in this sense. We have now an European funded program to educate people, let's say specialists and general practitioners to prepare them for testing these patients and link them to care. And we have also a pharma supported campaign now, working good, actually working very well. Regarding the, let's say, microelimination in academic centers, initially in 4 academic centers in Romania, where we actually are intending to test all the people, all the patients coming in this hospital and academic centers, and we hope to extend this over the next weeks or months. We have money for this, we have ideas, but I think we have also human resources and energy.
That sounds fantastic.
Thank you for the nice presentation, and I think that we'll move to another room, yeah.